And we haven't got the chairperson for the session and the moderator as well. So I'll moderate, I'll chair the session, and I'll present as well. That's an honor for me today. Right. I'm going to do the donut keratoplasty, which is a newly developed procedure which I developed myself for a particular type of keratoplasties. So anyone who's interested in cornea, that will be loaded on my website very soon. So what's donut keratoplasty and why I'm doing it? Right. Actually, I wanted to fit it within 7 minutes. So I've only talked about the general things, the pathogenesis, and then the treatment, which is actually donut keratoplasty. Corneal neovascularization, CNV, but the CNV also stands for choroidal neovascularization. So what we use it for the KNV, for the corneal neovascularization, because it mimics the choroidal neovascularization. So that's KNV is the word used for corneal neovascularization in the literature. Now, just briefly, what's angiogenesis, vasculogenesis, and neovascularization? Angiogenesis is the formation of new blood vessels from the pre-existing vasculature. Vasculogenesis from the bone marrow cells, and neovascularization is a combination of these two. So that's neovascularization is slightly different from the angiogenesis and vasculogenesis. And we are going to talk about the neovascularization today. Welcome, General Saab. We were waiting for you actually. I'll carry on. Right, just shortly about the pathogenesis and then directly go to the video. We all know the cornea immune privilege, that their organs, there is special protection for the cornea and its immune privilege. That's why the corneal keratoplasty is so successful. A new word that has come into the literature is angiogenic privilege. So the cornea not only has got immune privilege, it also has got angiogenic privilege because it's avascular. Why the cornea is avascular? Because there's a balance between provascular factors and antivascular factors. So there's upregulation and downregulation of anti-VEGF factors. If there's upregulation of the anti-VEGF factors, VEGF factors, then there's corneal vascularization. When both are balanced, then there's no corneal vascularization. So what happens? If you have got a corneal disease, and if the pro-VEGF factors have increased, there'll be corneal neovascularization. If you have treated and if the cornea has been epithelialized, that's the key factor. Then the anti-angiogenic, anti-vascular factors, they are more active than the pro factors, and then the vascularization doesn't happen. That's why every corneal disease doesn't end up with a corneal neovascularization. So mostly the bacterial and fungal, they don't end up, and the viral ones, they get more often get the neovascularization, because in the viral infections, the epithelium is damaged, and these all the VEGF, the upregulation of the expression of the VEGFs happens, and that's why the cornea gets vascularized. So what happens following the corneal injury? It normally heals, but sometimes it doesn't heal, and starts on the day 1 to 3, the vasodilation starts, and then on the day 7, you can see the blood vessels, and then on the day 14 plus, you can actually see the fully formed new vessels in the cornea. So that's how the corneal neovascularization happens. Now, the treatment. If the cornea is vascularized, as a surgeon, I'm interested in treating that. So how we treat it? The main problem is we want to do keratoplasty, and we have got loads of problems doing keratoplasty. The one thing is, because of the blood vessels, many factors come into the eye, and they cause the rejection of the graft. Plus, the surgery becomes very difficult. So I've made the surgery a bit easier. When you're doing the surgery, when you cut the cornea, the whole cornea bleeds, and you don't know where you are. You don't know where your trephine is. You don't know where your cut is, and you don't know which way the scissors are going, and you don't know where the anterior chamber is. Because of that bleeding, you cannot do a perfect surgery, and there are more chances of complication, like touching the lens and going into the anterior chamber. So, how to treat it? The best thing is to ignore it. If the blood vessels are just few, just leave them, and if the patient has got a reasonable vision, just carry on with them. Laser photocoagulation, I've done many times, never successful in my hands. cautery to the main feeder vessel, I do it routinely, but when there's a one feeder vessel, I do the cautery to the feeder vessel, and then secondary procedure is the keratoplasty. Ligation of the feeder vessel is another procedure I do. I pass a stitch around it and then ligate it and then do the keratoplasty as a secondary procedure. When there are loads of blood vessels all around like this, now you cannot ligate it, you cannot cauterize it, you cannot do anything else. So you have to live with it. And what you do is, this is the type of the cornea for which I have devised the procedure. Now this vascularized cornea, what I do, I make a cut with a trephine, and then with the crescent blade, I make all around like we do it for the DALC. So for the DALC, you remove the upper stroma. Here I've removed the upper stroma in a circular fashion and left the central cornea as it is, and I'm letting it bleed. It's bleeding from here, it's bleeding from here, it's bleeding from here. Because this looks like, now you treat it for a few minutes and it gets dry, because it looks like a donut, so I've named it donut keratoplasty. So what happens? Okay, I'll just go back to this slide and I'll describe it, what I do. When I've got something like this, I use a trephine, I make a cut, then I make a donut, and then what I do, I wait for 5 minutes, I put some adrenaline on it. So I do three things together. One is I soak this well with the adrenaline. That stops the bleeding through the small blood vessels. Then if there's a big feeder vessels, I ligate them or I cauterize them, and the combination of them, it just works together. And after 5 minutes, look at that, how dry it is, not a single drop of blood. And then I do the full trephination, and I just do the penetrating keratoplasty as usual. The question is, why the blood vessels don't grow again? Because the cornea is vascularized. So why, look at the cornea initially. This is all vascularized. Why the cornea doesn't vascularize again? Because that if you go back to the slide, there's upregulation of VEGF and downregulation of VEGF. When you've got a healthy epithelium, then because of the healthy epithelium, anti-VEGF factors are more active than the pro-VEGF factors, and the cornea doesn't vascularize again. Thank you very much.
Bismillah ar-Rahman ar-Rahim. Respected seniors and colleagues, Assalamu alaikum. I am Dr. Sidra Malik, and I would like to discuss my recent experience with a very rare and emerging pathogen that we used to generally overlook as students. This monsoon marked an unprecedented rain spell throughout Pakistan, which caused massive flooding. I am stationed at one such place, that is Jacobabad. In addition to carrying out flood-related activities, I encountered a diagnostic dilemma as an eye specialist, which I would like to share with all of you. My first case was a 14-year-old girl, a student in Jacobabad, who presented with a 4 days history and with mild retinitis, discomfort, and in her right eye. Her ocular examination revealed a visual acuity of 6/9 partial and superior bulbar congestion. Corneal examination showed multiple coarse epithelial opacities more marked in the supratemporal quadrant. Keeping in mind the corneal findings, a provisional diagnosis of Thygesen superficial punctate keratitis was made, and I started her on topical lubricants and a steroid antibiotic combination and called her for follow-up. Surprisingly, 3 days later, a similar case reported, this time a 36-year-old male optician who reported with a rather severe presentation of the same disease. He had pain, redness, photophobia, foreign body sensation. Sir, may I start? Sir. Surprisingly, 3 days later, a similar case reported. This time he was a 36-year-old male optician who presented with a rather severe presentation of the same disease. He had pain, redness, photophobia, foreign body sensation, and watering of the left eye for the past 5 days. It is pertinent to mention that he was actively involved in free medical camps in the flood-affected areas few days prior to these symptoms. He was advised topical Dexa-Tobra combination and topical acyclovir ointment from a private clinic, but he was only getting worse with that treatment. His ocular examination revealed a visual acuity of 660 in his left eye, along with upper and lower lid swelling and redness. There was diffuse conjunctival congestion and chemosis. Again, the corneal examination showed multiple diffuse grayish-white punctate epithelial and subepithelial opacities with well-delineated margins. Underlying endothelium and anterior chamber were unremarkable. Fluorescein staining revealed extensive epithelial staining and superficial punctate keratitis. Since the patient's condition was worsened by the Dexa-Tobra combination, and I had already established a link between the floods and this disease, so I decided to review literature and also consulted my mentor, General Mazhar Ishaq, for his opinion and guidance on these cases. I planned corneal scrapings for debridement as well as a diagnostic measure. Unfortunately, the pathologist of my hospital was on emergency leave. So with the help of the lab tech, initially I prepared and reviewed the gram stain slide myself. It took me quite some hours before I was able to spot what looked like spore of microsporidia. And later on, I got these slides reviewed at FIP Rawalpindi Microbiology Department. The patient was hence labeled as suffering from microsporidial keratoconjunctivitis. And in line of published literature, his topical steroids were shifted from dexamethasone to milder fluoromethalone, and that too in a tapering dose. He was started on topical moxifloxacin 2 hourly and fluoconazole 4 hourly, and along with topical lubricants and oral doxycycline. On the 5th day of treatment, the patient came back with marked relief of symptoms. Cornea showed only this small island of disease which was left. And this too became clear on his second follow-up just after 3 days. By now, his vision had improved from 6/60 to 6/12 partial. The lid swelling and conjunctival chemosis had markedly diminished as demonstrated here. While I was contemplating these two cases, a third case also reported. And by now, this case report had converted into a case series. Now, a 24-year-old female presented in my OPD with similar complaints and similar corneal findings. So she was diagnosed clinically as a case of MKC, and on the same lines she was treated, and she responded very well. Within a week follow-up, she showed complete healing and drastic improvement in her symptoms as well as her vision. Coming to the case discussion. Sir, isko present abhi. Coming to the case discussion. Flood-affected regions serve as ideal breeding grounds for pathogens, and this causes spread of disease. And this is further aggravated by the poor hygienic conditions in the camps and the tents that are already being set up. It is essential that those who are involved in the relief efforts should be aware of the epidemiology of diseases that have historically seen a sudden upsurge after the natural disasters. A study was conducted in 2010 in KPK, in which they also identified eye infections. They were also reported in the acute settings. Microsporidia are human and animal infecting obligate intracellular spore-forming parasites. They were first discovered in 1857 in silkworms, and there are 1,300 species, amongst which 13 are reported to infect the humans. As they are considered waterborne pathogens, their main factor highlighted in all the studies was the spread of this disease from exposure to contaminated water, from rainy season, floods, swamps, even swimming pools and ponds. Hence, I reiterate that my cases also started emerging after these recent floods. The first case of corneal microsporidiasis was published by Ashton in 1973, and it is the second most, ocular disease is the second most common clinical manifestation of microsporidia. Once classified as protozoans, they are now considered closely related to fungi. Historically, this infection used to be present secondary to AIDS. However, there are now increasing reports of microsporidiasis in the immunocompetent as well, like in the 3 patients that I had. This condition, unfortunately, often goes undiagnosed or misdiagnosed by the eye specialists themselves. There are basically two forms of the keratitis in microsporidia. One is the epithelial form, and the other is the stromal form. The stromal form is more severe. It has a guarded prognosis, and usually this leads to corneal transplantation. When considering the differential diagnosis, the morphology of the infiltrate, it is the key distinguishing feature, as these are larger in size than the nummular infiltrates in viral keratoconjunctivitis. Light microscopy after staining is the most common and feasible technique for the detection of microsporidia. Furthermore, transmission electron microscopy and these novel investigations can be carried out wherever available. Literature showed that fumigaline and albendazole have demonstrated the most antimicrosporidial activity in vitro. Topical fluoroquinolone monotherapy. So there's a glitch in it, I think. मैं फिर से करती हूँ उसको. So literature has showed that fumigaline and albendazole, they have the most antimicrosporidial activity. Topical fluoroquinolone monotherapy has shown promising results in sustained symptom resolution. In addition, topical voriconazole, propamidine, and topical fluconazole have also been implicated. Most authors do not recommend the use of topical steroids because that causes a local persistent immunocompromised state. However, there is a school of thought that says that if we don't give steroids, then there is going to be subsequent formation of nummular keratitis, uveitis, and stromal haze. A study found that all patients with epithelial disease who underwent debridement, they achieved resolution without recurrence. The National Institute of Allergy and Infectious Diseases of the United States has already labeled microsporidia as a Category B emerging pathogen. Moreover, the Environmental Protection Agency has placed microsporidia in contaminant candidate list 2 category. So this case series is the first ever reported ocular microsporidiasis in Pakistan. I would conclude by highlighting to the audience to generate awareness regarding this rare ocular waterborne disease, especially to those who are involved in eye camps at remote flood-stricken areas. Drainage of stagnant water should also be carried out on priority. Lastly, corneal scrapings can not only serve as a diagnostic, but a therapeutic tool as well. I thank you all for your patient listening. If there are any questions, then I'll... Sir. Sir, usually it has been 90% of the time it has been labeled as atypical adenoviral keratoconjunctivitis. So what happened was when you start, even in these cases, they were already on steroid that we usually give to these patients. But in a week or so, in even 4 or 5 days, they were actually getting worse with steroids. This first thinker that was giving a pointer towards a different diagnosis was this. Secondly, it was a non-purulent conjunctivitis in the 3 cases. There was absolutely no history of and no clinical appearance of discharge or matting of lashes. And it was strictly unilateral presentation in the 3 cases. And there was absolutely no history of contact as well. So we usually see adenoviral nummular infiltrates, but this was even on the slit lamp. I don't know if I have been able to catch good pictures, but the clinical picture of nummular infiltrates versus these was entirely different. These were really well demarcated, and they were epithelial and subepithelial, and staining was also positive. So it was clinically, if you would ask me, even I discussed with sir, even if we did not do the corneal scrapings, at least it was not adenoviral to us, anything but that. So this was on the biopsy, it was on the corneal scrapings. Furthermore, we could visualize the spores as well. So I think usually it has been labeled atypical adenoviral in the past cases if they've ever emerged.
Try to check up the lymph nodes, the auricular lymph nodes in this
So no
cases.
no sir, no because there are just 3 patients, so there were absolutely no.
The thing is that it was even not whether it is a protozoa or whether it is a ये भी नहीं पता ना वो है चीज़ क्या है originally. लेकिन the important thing is to remember that if you have this diagnosis, the treatment, it is all antifungal. So that is something which has to be taken, which is a completely different scenario आया था, and treatment point of view से, if you have this.
Yes sir. So
I think if I see such a patient, I'll label it as a viral.
Viral. Yes. Exactly.
Basically, something one should be knowing it, and the treatment, which is the most important thing, is
So,
really made a big difference.
so they were all unilateral. Absolutely, the other eye was fine, and even otherwise, beyond the anterior epithelium and subepithelium, everything was fine.
Viral infections are usually bilateral.
And sir, it should have responded somewhat to the steroids that was already taken from the civil setup, the steroid Tobradex, and the other person also started on acyclovir ointment. He was thinking something maybe. So now the newer taxonomy, they have taken it out of the protozoans, and the features are now closely resembling to fungi. And the I think most convincing evidence is the response to the antifungals. So there are studies they're showing. Yes, sir. Fluconazole. Sir, I did give him fluconazole because voriconazole was not available in Jacobabad. And secondly, he arranged the diflucan vial, and I immediately changed the treatment on the same day I did the debridements. So within 3 days, I think it was the effect of the debridement, debulking as well, and secondly, I started him on antifungals, even the other patient. And when I stopped their steroids, I couldn't take the leverage of stopping them completely, so I shifted from dexamethasone to fluorometholone, and that 2 thrice a day. I did keep giving them, but I shifted to antifungals and moxifloxacin, just moxifloxacin.
The combination of quinolones along with antifungal, that is because the etiology that itself, it is you are not sure what kind of, it's an antifungal protozoa, so it's antibiotic plus antifungal.
Yes.
That really works. Otherwise, otherwise it doesn't make sense. How can an antibiotic start working on this?
Thank you very much, Dr. Sidra.
Thank you
very much for your time.
Thank you, sir.
We haven't got the moderator or chairman for the session, so I'll act as a moderator. With this, we conclude the session, and I would like to request General Mazhar Ishaq Saab and Hafiz Saab to come for the presentation ceremony, please. आजे सर वो किसके पास है शील्ड्स Can I request Dr. Sidra please to come? इसकी पहली दफा
और मियाँ फोटो ले रहे हैं लो जी और उधर शीट में
ठीक है ठीक है तो आप देख लें स्लाइड शो वीडियो है नहीं
हाँ बहुत ज़रूरी है
टाइम है तो
स्लाइड शो नहीं होनी ये इधर यानी स्लाइड्स तो नहीं स्लाइड शो चाहिए
शीट भी नजर आएगा
थैंक यू वेरी मच थैंक यू
अच्छा जी अब आप छुट्टी क्या ठीक ठाक हो